slide. An additional body of evidence that demonstrates that caplacizumab and immunosuppression without plasma exchange is a safe and effective treatment in achieving clinical remission for the majority of patients with immune TTP, and with particularly those who do not have severe neurologic and cardiac impairments as demonstrated by the randomized controlled trial. So this was effective, it was rapid, and it's a very feasible approach, albeit it requires close monitoring to make sure that patients may require salvage TPE in case the treatment is not effective in the minority of patients. And safety profile was good in the randomized controlled trial with no new safety concerns identified. And so this is definitely a very good new data to have that provides us great evidence to support a brand new approach in the management of TTP. And this has the potential to be a practice-changing trial. Now, in addition to caplacizumab, so going back to my earlier diagram, there is interest in using different approaches, such as recombinant ADAMTS13, which is approved for congenital TTP. And recombinant ADAMTS13 is of interest in immune TTP because it is postulated that it can lead to immune complex formation that may saturate the autoantibody, and by doing so, promote the clearance of the autoantibody, and then replete the ADAMTS13 that is deficient, and by so treat the disease. So this is a promising upcoming treatment for immune TTP without plasma exchange. It is currently under investigation in a phase 2b trial, so we don't yet have data about it. And when that trial, it is being investigated with minimal to no TPE. So hopefully in the future, once enough patients have been enrolled and analyzed, we'll have data about it. So with these updates, to me, it seems like there is a changing landscape in the future management of immune TTP. There's interest in making the treatment of immune TTP plasma exchange free. And by doing so, patients do not have to go through the process of getting a catheter and remain in the hospital or be subjected to the complications of TPE. And ultimately, the hope is that that improves access to care, early treatment of TTP, as well as improve outcomes as a result of that. There is also future directions in looking at other treatments, such as novel methods of immunosuppression. Immunosuppression is a key component in the management of immune TTP, especially those who have relapsed. And currently, we use rituximab as a first-line immunosuppressant. However, there is data to support the use of other immunosuppressants, and as well as different approaches in terms of which aspect of the immune system we are targeting in order to treat the disease. And this is also something to look forward to in the future in terms of looking at novel therapeutics that address the immune component of the disease, in addition to the recombinant ADAMTS13 or caplacizumab. So my hope is that the main cornerstones in the future of the treatment of this disease are going to be these three big items here, which is immunosuppression, caplacizumab, and recombinant ADAMTS13, which will present to be a practice-changing or paradigm shift in the treatment of TTP. Thank you all.